we've experienced childhood trauma shrinks. And the emotional regulation part of our brain, where we can sense emotions and calm ourselves down, that shrinks too. And the amygdala, the fear center part of our brain, where we experience stress and emotional stress, that grows. And so we could become very afraid. So if we don't recognize and treat childhood trauma, then this kind of changes continue. But this is treatable. And actually, if we can do behavioral therapy, that these changes go back the way they're supposed to. The amygdala shrinks, the part of our brain where we make good decisions grows, and our ability to regulate our emotions improves as well. So it's not just adverse childhood experiences, it's the community in which we grow up too. So if our community experiences poverty, discrimination, lack of opportunity such as jobs or recreation, poor housing quality, those are stressors as well. And it goes beyond our community too, actually. If our history, our ancestors experienced stresses such as forced relocation, war, economic depression, that has changes and changes and changes and changes. So what is addiction? And I'll read this definition, it's kind of dry. Addiction is a treatable chronic medical disease involving complex interactions amongst brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and continue despite harmful consequences. But it's treatable. So treating substance use with medications and behavioral therapy is just as effective as treating diabetes and high blood pressure. So what's addiction medicine? What is this specialty? What are we doing? So we are our own specialty. It was recognized in 1990, and it's concerned with prevention, evaluation, diagnosis, treatment, and recovery of persons with the disease of addiction, of those with substance-related health conditions, and of people who show unhealthy use of substances. And those include nicotine, alcohol, prescription medications, and licit and illicit drugs. And in 2016, it was formally recognized, addiction medicine was formally recognized as its own subspecialty by cardiology or pulmonology. So an important thing to recognize is that formally we used to, as our society, look at addiction from a moralistic standpoint. So people were just weak-willed or they chose to live this way, and we punished them and we locked them away. But we have come to realize that punishment only teaches what not to do, but it doesn't teach what to do instead, and maybe someone never learned. And that also, the medical community itself creates fear in patients that use substances, and because we frankly have treated people with addiction very badly, and people are afraid to seek care. So we start with changing our language, and these are our labels, words like drunk, alcoholic, pothead, junkie, tweaker, addict, drug abuser, drug seeker, addicted baby, and the words clean and dirty. So like saying, describing a urinalysis or urine drug screen. The urine may be positive or negative, but it's not clean or dirty. Those are judgments. So professional language to use. Person with alcohol use disorder, person with opioid use disorder, person with stimulant use disorder, person with cannabis use disorder. Because remember, this is a person first, and most likely they've been hurting. So how common is substance use? It actually affects about half of families. And it doesn't matter if you're a man or a woman, or you went to college, or you didn't go to college, you go to church or not, it's still about half. So addiction. Addiction is a learned behavior. No 4-year-old wakes up and tells their parents, when I grow up, I'm going to be an addict. It's learned. So how do we learn? We learn from something called operant conditioning. So if we want a behavior to keep happening, we reward it a lot of times. And if we want a behavior to stop, we punish it. So there's a concept called positive reinforcement. So like this example, if I want the puppy to lie down, I reward him with a dog biscuit. If I have a little social anxiety and I want to have a good time with my friends, I get really trashed. Negative reinforcement, strengthening a behavior that avoids or removes a negative outcome. In this example, I've learned to use sunscreen to prevent a painful sunburn. We learn to use substances to take away negative feelings. Positive punishment, decreasing a behavior by introducing an unfavorable outcome. The puppy has chewed your boot, so you yell at it. Hangovers. Negative punishment, taking something good or desirable away to reduce the occurrence of a particular behavior. Timeout, adult timeout. So this is a brain. This is a cutaway of the brain. And the important thing to notice is that there's a part of our brain that has a lot of drug receptors on it. And that when these drug receptors are touched with these chemicals, then it makes this chemical called dopamine. And dopamine is a really strong feel-good chemical. So why do we have dopamine? We have dopamine in our system because it rewards us for things that improve survival. So this is a model of a rat brain. And this is the rat at normal, it has 100% dopamine, and when you introduce food into its cage, it goes to 150. When you introduce a sexual partner, it goes from 100 to 200. Woohoo! These are drugs. So, nicotine goes from 100 to 250. It's better than sex. Cocaine, wow. 100 to 350, and look at amphetamines, 100 to almost 1200. So there's nothing in the natural environment that simulates that level of dopamine. And that's why it's so hard to treat. Also, we know that the addictive potential of a chemical is related to how fast that dopamine goes up and how fast it goes down. So this is dopamine. And this is the brain, and I'm going to discuss the 3 phases of addiction in the brain as we know it now. So the first phase of addiction is called the binge intoxication phase. So this is the reward phase. This is the positive reinforcement phase. So we use chemicals, we feel good, we want to do it again. We want that feeling to continue. And that creates in our deep brain something called a stimulus response cycle, because we want to keep that good feeling going, and we don't even think about it. Kind of like if I put 3 warm chocolate chip cookies in front of you, if you're a little stressed or distracted or whatever, you might think about eating that first one, but if you're not really paying attention, that second and that third one for sure are gone, and you don't even know why. That is the binge intoxication phase. The second phase of addiction, this is the negative reinforcement phase. This is people using substances to get rid of negative feelings or emotions, withdrawal, negative affect. What's going on? So after we've been experiencing a whole bunch of dopamine from binging over time, the brain doesn't really like that. It wants to balance out. And so in response to dopamine, over time, it makes this chemical called dynorphin, and that's a feel-bad chemical. A stressful, I feel like I'm going to die, I need this horrible feeling. And so it continues. When someone is in very early recovery, that dopamine, that substance, that thing that was making the dopamine is gone. But that dynorphin, that bad feeling, that bad chemical, continues, and it continues for a long time. So when someone is using alcohol and they're having a life-threatening withdrawal, we put them in the hospital for 4 days or 5 days or so just to get them through and prevent that DTs. But that withdrawal, that dynorphin feeling, goes on for weeks and weeks and weeks. Heroin goes on for months that people feel bad. So if someone goes through detox, they still feel bad for months and months and months. Benzodiazepines like Xanax or Valium last almost a year, and the drug that lasts the longest is cannabis. Cannabis withdrawal lasts an entire year. So people forget why they think, oh, well, I'm anxious from, I used marijuana to treat my anxiety, and when I don't use it, I'm more and more anxious. Well, that's going to happen for a whole year. But with this withdrawal, we can actually treat that with medications. If we recognize that, and we can treat it, it's pretty awesome. So we can get that bad feeling away so that people can actually focus on their recovery. Because if people are feeling bad for months and months and months, and they know exactly how to make that feeling go away, well, then that's going to cause an early relapse. So the third phase of addiction, we call this the preoccupation, anticipation, or the craving phase. And so this is cues in our environment. In treatment, we call it people, places, things, and situations. So certain things trigger us to want to use or start thinking about it and start developing cravings. Those may be positive reinforcing things, they may be feel good things, they may be feel bad things. But it makes us want to use substances. An example, marketers have known this for a long, long time. And so the alcohol industry and the beer industry have pretty much made it so that you can't watch a football game unless you're drinking beer. Also, the alcohol industry did some studies on women, and they found that women of childbearing age were the least likely to drink alcohol. And so over the last 20 years, there's been a targeted marketing campaign to get women to drink more alcohol. An example of this is Mommy Wine Time. And now women drink as much alcohol as men. But it's not just adults. Big Tobacco has made a targeted campaign to children because of tobacco cessation and that being very prominent. Adults actually reduced their smoking. And so they needed a new market, and so that's what vaping is. So when you put these three phases together, binge intoxication, withdrawal, negative affect, and the craving phase, if we don't interrupt this cycle, then it can lead to a terminal illness.
All right, so now we're going to talk a little bit about diagnosis. So how do we diagnose substance use disorders? So first, let's talk about the difference between dependence and addiction, because I think that sometimes this needs to be clarified a little bit. So dependence is a combination of two factors called tolerance and withdrawal. And opioids are a great example of this, because when you're using opioids for even a short period of time, you develop dependence on them. So they start to work less, and you start to feel bad when you stop taking them. Dependence from opioids happens in as little as 5 days, but that's not the same thing as addiction. Addiction is defined by our behaviors. So addiction are the things that you do when you are needing that substance. And we refer to this as the 3 C's. So craving, consequences, and a loss of control. So if you're using despite consequences, that's when it becomes addiction. So in other words, if somebody winds up in jail as a result of their use, then that's addiction by definition. So this is the DSM-5 criteria for substance use disorder, and I'm going to just read these, so bear with me. But number 1, substances are often taken in larger amounts over a longer period than was intended. Number 2, there's a persistent desire or unsuccessful efforts to cut down or control substance use. Number 3, there's a great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effects. Number 4 is cravings or a strong desire or urge to use the substance. Number 5, current substance use resulting in a failure to fulfill major role obligations at work, school, or home. 6, continued substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of the substance. 7, Important social, occupational, or recreational activities are given up or reduced because of substance use. 8. Recurrent substance use in situations in which it's physically hazardous. 9. Continued substance use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by this substance. And then 10 is tolerance, and 11 was withdrawal. So if you just have number 10 and 11, you're dependent but not addicted, and this is how we actually diagnose people with addiction. But as you can see, if you kind of think about some of these things, it's pretty easy to meet these criteria. So a lot more people, I think, are struggling with addiction than we even realize. And then we further grade this on a severity based on the number of criteria that they meet. So a mild use disorder is 2 or 3 of those items on that list, moderate 4 or 5, and severe is 6 or more. And the majority of people that are using illicit opioids have a severe use disorder. So what does treatment look like? Well, in a perfect world, treatment is a partnership, an alliance between behavioral health providers and medical providers. We feel like it's our job to help people to get through their withdrawal, to, basically to help them to cease using substances by providing them with medications that allow them to focus on their therapy. It's super important that we work on the root causes of addiction. So medications are extremely helpful, but they're not everything. And I don't believe that. That's not my philosophy in terms of treatment. So in order to treat a substance, you need to know what its primary reinforcement type is. And it's different for different substances. So stimulants, like cocaine, amphetamine, and caffeine, are very strong positive reinforcers. The negative reinforcers, like opioids, alcohol, sedative hypnotics like Xanax, nicotine, and cannabis, people mostly use those because of the withdrawal state. Most of the time, people are only using because of the negative effects that occur when they stop. And that's why it's really important to recognize that. Most people that have an opioid use disorder, at some point, they're not using to get high anymore. They're using so that they don't feel like crap. So you have to understand that. So we work to provide treatment, can be providing reinforcement in a healthy way. So this is things like contingency management, where we reward people for doing well in their recovery. The community reinforcement approach, which is where we teach people to re-engage in things that are rewarding. Community reinforcement through family training or craft, which is where we get the family involved to help to reward good behaviors and also let people sometimes suffer the natural consequences of bad behaviors. Phased treatment, such as occurs in opioid treatment programs, where people get to have a little more leeway with taking more doses of their medications home as they move through the program. And then also mutual health groups like AA, NA, SMART, Wellbriety. These are amazing for helping people to get some positive reinforcement. They get a really good, attaboy from the rest of their peers when they're doing well in their recovery. And that's awesome. And also, we also work to treat the negative discomfort by decreasing negative reinforcement rather, by decreasing people's discomfort. Sometimes that can be as simple as social interventions. Like if somebody's homeless and hungry, it's really hard for them to focus on the recovery. So finding people something to eat and stable housing can do a lot to promote their recovery. Trauma therapy, cognitive behavioral therapy, where we teach people new coping skills. Dialectical behavioral therapy, where we teach people emotional regulation and communication skills. Mindfulness, something called acceptance and commitment therapy. And then, on that list on the right, there's a whole list of medications that we use to help people feel more comfortable while they're working on their recovery.
I have a question.
Yeah.
As far as like Suboxone,
Yep.
how long would a person who is doing that form of treatment be on that? Because I've heard up to like years and years, and I'm going to put myself on blast, okay? Because I was addicted to opiates at one time, and honestly, Suboxone would have been my drug of choice.
Yep.
Had I have, went that route.
Yep.
And for me, it was, I went through the whole thing. It's so much better. But I hear people being on there for years on this.
Yep.
Why?
All right, that's a wonderful
I
question.
want to know why, because if it would have been my drug of choice, I know a lot of people out there who would be their drug of choice too.
Yep.
Who would just be switching one thing for this medication-assisted treatment that was legal.
Thank you so much for pointing out the elephant in the room and the question that everybody always asks, because I would love to take this on. So, the natural tendency for people on Suboxone is to remain on Suboxone for between 1 to 3 years.
Okay.
But there is no definite timeline. When we see patients coming in to see us and they ask, how long am I going to be on this? What we say is, you're going to be on it as long as you need to be on it. because everyone's different, everyone responds differently to that, and it's important to understand how Suboxone works. So I can tell you what Suboxone is and what it isn't. So Suboxone is an opioid, but it's what's called a partial agonist. So the part of your brain where opioids act to cause euphoria and to cause people to get high, it has very little activity on. It blocks withdrawal by sitting on something else called the kappa receptor. The kappa receptor is the bad feeling that she was talking about, the dynorphin. It blocks dynorphin. Thing is, everybody always has a little bit of the dynorphin in their body all the time. So when you block the dynorphin, it actually acts as a really strong antidepressant. So if you find yourself needing it or thinking that it's probably the drug you need to be on for the rest of your life or you want that feeling, it's because of the antidepressant effect, not the euphoric effect of it. So most people who are on Suboxone for any period of time, when you ask them how they feel, they'll tell you they feel normal. Now, if you buy, if you get one off the street or something like that, and you're naive to it, you've never taken it before, you're going to feel something. But after being on it for a short period of time, any euphoria goes away, and it comes down to just blocking withdrawal and then having a really potent antidepressant effect. So we don't encourage people to get off of it. We tell people to stay on it as long as they need to be on it. When they ask, when will I know? It's like, well, how would you know if it was, time to stop your diabetes medications? Well, maybe you work really hard, you exercise, you lose some weight, you change your diet, you might be able to come off your diabetes medications. But how many people, wind up being able to do that within a short time frame? So it may take some time for people to achieve those milestones that allow them to come off of it. Some people come off of it pretty quickly. It's actually much easier to taper off of Suboxone than it is off of other opioids like fentanyl or methadone or heroin, and the withdrawal isn't nearly as bad. So people do tend to wean themselves off, and what we usually do is when people have started telling us that they're skipping their doses and that they've started, weaning themselves down, then we just help them through that, and and we just get them a little more therapy, and we try to just work with them while they're doing that. But the tendency is for people to be on it between 1 to 3 years. If that answers your question. Cool. All right, so we're going to talk a little bit about medications for addiction treatment, and this is a good time to actually talk about what you just pointed out. And so there's 3 medications that we use for opioid use disorder. They're buprenorphine, or Suboxone, which is called a partial opioid agonist. Methadone, which is a full opioid agonist, and methadone is one that a lot of people know about, and it's gotten a pretty bad rap, because methadone clinics have been around since the 70s, but I can tell you that methadone, does work really well for some people. It's not a first-line medication in our world. It is something that, we need to kind of we need to have it available because, especially with fentanyl being as powerful as it is, it's an inevitability that some people are going to wind up needing methadone, and that's just the way it is. And then the last one is Naltrexone, and Naltrexone is really popular. It's an opioid blocker, so it blocks the effect of opioids, and you give somebody an injection with this. Problem is a couple of things. One, it's really hard to get people started on it because they have to be off of all opioids for 2 weeks before they can start. So it's really hard to get people onto it